Hi, my name is Elise, and I have a report on patient Janice Jordan in room 5201. We are on a med-surg floor. The client was admitted on 8-1 for urosepsis. We later found that she's been struggling with medication compliance related to her congestive heart failure, and after admission, she did fall in her room, resulting in a hip fracture, but she isn't stable enough for surgery yet, so she is on Bucks traction. Her medical history includes congestive heart failure, diabetes, and a UTI. We can assume a full code status, and she has no known drug allergies. Standard precautions should be used, but it should be known that she's at risk for sepsis and distributive shock. Her primary doctor is Baxter, and she has consults with an orthopedic surgeon as well as wound care. We are currently monitoring her oxygen saturations, but they're bouncing around quite a bit. Cultures have been sent in regards to her urosepsis and blood. The priority at the moment is stabilizing her for orthopedic surgery. A CBC was drawn twice today at 05:45 and 10:40, as well as blood chemistries, which found the same values on both. So her RBCs were 4.8, hemoglobin 11.3, hematocrit 33%, white blood cells 13,000, and platelets 220,000, with reticulocytes at 0.78%. Her electrolytes are all within normal limits, but BUN is elevated at 21, albumin is 3.2, and cholesterol is 225. Urinalysis was taken at 05:45 and found cloudy, slight amber urine without odor. The specific gravity was concentrated at 1.039, pH 5.6, protein 2 milligrams, and was positive for white blood cells, red blood cells, and casts. ABGs were taken at 03:45, which found metabolic acidosis, so her pH was acidic at 7.28, oxygen was 88, carbon dioxide was 35, and bicarbonate was at 20. She has activated C protein in blood cultures that were taken at the same time, but the results are still pending. For radiology, a chest x-ray at 10:40 found left ventricular hypertrophy, which makes sense with her congestive heart failure diagnosis, as well as mild COPD, pulmonary dilation, but no evidence of focal consolidation in the lungs. After her fall, her elbow was x-rayed, which was not injured. However, her left hip and femur x-ray at 1400 found a femoral fracture. Her current vitals at 2400 were temp 101 Fahrenheit, heart rate 98, respirations 24, blood pressure 128/82, and oxygen 85% via nasal cannula on 4 liters of oxygen. Her INOs are on the chart. She is alert and oriented ×4, but is restless and anxious. She currently doesn't use oxygen at home, but there are orders to titrate oxygen as much as needed to keep her stats above 90%. AccuChecks are ordered at mealtime and before bedtime. They've consistently increased, and her last AccuCheck found 136 blood sugar. A 22-gauge catheter has been inserted in the left peripheral extremity and is patent, infusing normal saline at 150 milliliters per hour. The client normally ambulates on her own, but is on constant traction on her lower left extremity. She is on a 2-gram sodium diet. In the ED, she received 2,500 milliliters of fluid, which basically flooded her lungs, so her respiratory status has been struggling. My assessments found labored, uneven, and shortness of breath with crackles bilaterally in the lungs. She is voiding with a Foley catheter on dependent drainage, but her INOs indicate that she's gained 2,300 milliliters of fluid since her admission. A stage 2 ulcer has been noticed on her coccyx, and she has orders for a barrier ointment to be applied twice daily and PRN for skin redness and irritation. She is also receiving PRN acetaminophen at 2,000 hours and 2,100 hours, which controlled her pain from a 4 out of 10 to a 2 out of 10. Her other PRN medication is lorazepam for anxiety and restlessness. and she is currently taking glyburide with breakfast, levofloxacin IV, digoxin once daily, albuterol with a nebulizer, and furosemide based on her voids. The client does live alone and was brought in by her neighbor, but she isn't close to discharge yet. I think the priority for your shift is keeping her oxygen stats above 90% by managing her congestive heart failure. This is going to be done through medications, monitoring the fluids in her lungs, and paying attention to what's being voided. So for her medication, she does have orders for furosemide, and if she doesn't void 500 milliliters within 6 hours of each dose, please contact the provider. By monitoring the fluid in her lungs, I would say with every dose of furosemide and every time you go and check her skin for that skin ulcer, go ahead and do a focused assessment. We really need to keep track of her INOs because she has retained a lot of fluid during her admission. In relation to her hip, she was really concerned and anxious about buccal traction, so she did speak with Dr. Baxter, but I think you should reinforce some education on continuing to move her toes in the affected leg to keep the blood flowing. I think you should also consult with the primary and the orthopedic surgeon about the future reduction of her left hip and what their goals are for stabilization. And in regards to that, her blood cultures should be back from the lab during your shift, and when they do get back, please contact Dr. Baxter immediately so we can start antibiotics, because if she is septic, she's not going to be stable for a hip reduction. She doesn't have any orders for skin assessments, but I think it should be done every 2 to 4 hours. She's only been on buccal traction during my shift, and she's already developed a stage 2 pressure ulcer. So we really want to keep an eye on that because she is prone to infection at the moment. Do you have any questions for me?